and welcome to a panel addressing stigma to ensure equitable and accessible TB care in India. TB does not discriminate. It can happen to anybody. TB-related stigma, however, discriminates against affected individuals and their families. The challenge is that even today, we dominantly address only the clinical determinants of TB in India. We ignore or half-heartedly acknowledge the stigma that affects individual health and their access to TB care. We think stigma can be addressed through just simple awareness and information. With this panel, we want to try and change this thinking. We will focus on the affected individual's experience of TB-related stigma, why addressing stigma is critical, and how we can address TB-related stigma to make TB care in India accessible and equitable. Let's have a look at our panelists. Our first panelist, Devashri Lokhande, is an XDR TB survivor and SATB fellow who is a vocal advocate on national and international stage. Her presentation sets the stage by highlighting TB survivors' experience of TB-related stigma and how this stigma impacts them. Next up, we have Dr. Karuna Sagili, a public health professional, Deputy Director, Knowledge Management and Research, ACSM NTSU at the Union Southeast Asia Office. She will present on why addressing stigma is critical to India's TB response. Then we have Dr. Ruwandi Nathavitharana, who is an Assistant Professor of Medicine at Harvard Medical School and the Chair of TB Proof and Advocacy Organization. She will present on designing interventions to end TB stigma, drawing on the South African experiences of TB stigma. Finally, we have Ashna Ashesh, a public health professional, lawyer, MDR TB survivor who advocates for TB affected individuals at the national level and whose work is informed by a rights-based approach to TB care. Her presentation will examine the ways in which law can be used to mitigate TB-related stigma in India. So let's get started.
Hello everyone, I'm Devashri Lokhande, an XDR TB survivor and a fellow with Survivors Against TB India. And I'm very happy to be speaking at the India TB Summit on this panel for addressing stigma for TB care in India. Stigma matters. I'm here to talk about understanding stigma, its impact, and learning from narratives of TB patients. So what exactly do survivor stories tell us? My journey with TB did not end with treatment end. For the sole reason that I wanted to effect a revolution in fighting the stigma surrounding TB. I had stayed quiet for too long, not anymore. So let's try to cover the intersectionality of stigma and TB. Here we are mainly going to try to study the sources of stigma and how exactly does it impact a TB patient, their life, their care, and life after care and their experience. So, let's talk about understanding social stigma. Social stigma is a stigma born out of the society. You're looking at it from the point of view of the case study of Tejal, who is a pulmonary XDR TB survivor. She faced stigma from her neighbors and the community. She was also stigmatized by the hospital staff until her doctor intervened. Her family too faced discrimination. Moreover, she was asked to hide her illness even after treatment end, just so as not to affect her sister's marriage prospects. This affected her mental health, this affected her self-image, and TB stigma affects families and patients even after treatment end. Let's understand social stigma from the point of view of Mansi's case study. She is also a pulmonary XDR TB survivor. She faced stigma from the community, specifically from the older generation of people they would advise her friends from against visiting her out of a fear of infection. And as a positive, heartwarming change, her friends would advocate for her and stand up for her, making those stigmatizing her understand that with the right precautions, one needed fear proximity with TB patients. This episode highlights the importance and the need for awareness and peer support to fight stigma. So, what are the key learnings from these two case studies that we learned about social stigma? Social stigma is primarily born out of a fear of infection. The myth surrounding TB, like TB, is genetic or it is incurable. These cause great harm to the image of TB, to the mental health of TB patients. There exists a cruel tendency to lay blame on the patient and the family. Poor awareness of TB feeds the myths and the stigma. And more importantly, stigma is gendered. It affects women and those of non-binary genders disproportionately. Let's study stigma from the point of view of a workplace or healthcare setting through the case study of Seher, who is a drug-sensitive TB survivor. She is educated and could afford private sector care. She faced stigma right at the first point of care from the doctor whom she had approached to seek care, who outright denied her treatment. The doctor somehow implied that it was her fault that she got TB. This stigma also reflects the social association of TB with class, illiteracy, and poverty. Moreover, she was afraid to share her diagnosis at her workplace. She felt that as a woman in a corporate sector job, when you try to show infirmities, you don't want to really be portraying yourself as a victim. This is because TB is stigmatized due to its association with poverty and social class. Let's look at stigma in a workplace or healthcare setting from the point of view of Diptendu. Diptendu's case study of an MDR TB survivor. He is an educationist by profession and a scientist by training. He faced stigma from his doctor who would refuse to enter his room, treating him like an untouchable. He faced stigma from his PhD supervisor who refused to work with him. These behaviors tended to affect his mental health, his self-image, and treating the patient as a culprit will only lead to a cycle of depression and self-blame. Let's look at stigma in a workplace or healthcare setting from the point of view of Divya. Her case study is she is a nursing officer at the AIMS hospital. She defeated TB thrice in an 11-year career and faced severe stigma causing distress and mental trauma. Her colleagues, fellow healthcare personnel, refused to be in proximity with her. This stigma born out of a fear of infection and desensitized community behavior. So, what do we learn from these three case studies? The health system can perpetuate stigma. Health workers need stigma training and information and awareness. The focus should be shifted from patient monitoring to treatment with empathy. Workplaces strongly need stigma mitigation programs. We need to create a holistic, sensitive program for patients to freely report or access help when stigmatized. They should not feel that they are fighting this battle alone and that there is a support system in place where they are heard and they are guided forward. Lastly, let's talk about internalized stigma through the case study of Dipti, who is an MDR-TB survivor and a patient advocate. Dipti fought a long battle with MDR-TB for 6 years, which included 2 surgeries. She faced internalized stigma after insensitive remarks and behavior of relatives and the community. She drastically self-stigmatized after a change in appearance when on anti-TB treatment. This highlights the need for affected individuals who need information on stigma mitigation. So what are the learnings of internalized stigma from this case study? That internalized stigma impacts a patient's will to complete treatment. It greatly determines a patient's experience and the mental and emotional trauma. Stigma created as a result from society, healthcare settings, media portrayal campaigns. These distort a patient's self-definition and causes them to self-blame and self-hate. Self-stigma is a learned behavior, but it is not impossible to mitigate and overcome it. And it can be done via sensitization, counseling, peer support, and awareness. So, what are the important lessons that we need to carry forward? Stigma is an imbibed response to created from a system which has turned a blind eye to TB. The fear of discrimination forces people to delay seeking care, leading to greater infection spread. Communication and awareness programs around TB stigma are all top down. And we need to realize that science alone cannot defeat TB. There needs to be proactive communication and sensitization programs. So, what is the way ahead? Stigma needs a comprehensive strategy. Legal and punitive solutions need to be in place for a patient to openly approach and use. There needs to be workplace and healthcare interventions. Myths and misconceptions must be addressed and destroyed from the root. Patient education is a must. We cannot eliminate TB without ending stigma. TB is curable, stigma too. Thank you.
I'm glad to be part of this panel to discuss about TB stigma in India. So we are discussing about why is it important to address stigma in India's TB response. Being a medical condition, TB is also known as a social disease. India is home for 2.6 million estimated people with TB, along with being a home for people with different languages and caste systems, cultural traditions, beliefs and traditions, and various ethnic groups. TB is disproportionately affecting poor people, especially the marginalized and vulnerable communities in India who already face inequalities and inequities due to various social structures. The various social outcomes of TB include stigma and discrimination as a major part. Stigma contributes to reduced marriage prospects, isolation, branding, dropping out of schools, leading to depression, illness, loneliness, poverty, and loss of employment, and several other consequential things that are linked together. The root cause of stigma is fear of infection, fear of death, fear of financial burden, and fear of social isolation. These fears are generally not addressed by the current means of knowledge that's being disseminated. There are several myths that are part of this knowledge, or the current prevailing knowledge around it. There are myths that the TB curse from God. It's due to people's sins, that gods are not happy with us. There are existing social structures which continue to sustain this stigma and these myths because of cultural beliefs that are entangled with the caste systems where stigma is also part of it. The current knowledge of TB that is being shared with the people also quite medicalized. We do not address the social aspects of TB in the knowledge that is being disseminated. So this often doesn't help in addressing the fears and the myths in the community. For example, as we look at various literature that is already there, Union has been working on this knowledge active practice practice surveys over the period of last decade. We have done 3 different surveys. What we understood is that the stigmatizing attitudes and discriminating attitudes are very high among the general population. So why is it? So why is that the correct knowledge of TB is it not associated? Why, when people have correct knowledge, do they still stigmatize? When we try to look at it, what we found was that stigmatizing attitudes were independent of correct knowledge of TB. Because it's not just the knowledge that they have, but it is also the various aspects of the social aspects that contribute to your attitudes. that inform your attitudes, that inform your discriminatory practices. And this, in fact, have a effect on the people with TB in various aspects, like leading to depression, so low self-esteem, self-isolation, hiding the history of TB because they fear that they may not get married because if people will get to know that they have TB, they will fear to losing job. So these things are kept in hiding. So this consensual framework gives us a very important image of why we need to address stigma in India. This is something like this iceberg, where a major part of is hidden. What we see outside is only a little bit, but what is hidden inside is not seen, and hence we perceive that it is not there. Social aspects of TB are largely like this. Why should I address TB when? Why should I address stigma for TB services? Does it affect TB services? Yes, of course. How does it affect? It is contributes in delay in seeking help. It contributes in delay in diagnosis. Apart from the technical aspects of diagnosis, it is the people who need to go and seek these services that they may not want to go because of the existing stigma and discrimination. There are reduced treatment adherence that happens. That is seeking in private sector because often government public sector hospitals are the ones which many people access, and they fear for confidentiality and they would prefer private sector, which also adds on to the catastrophic cost due to treatment. So there are various threads attached to this. This is not as simple as we think. And this is again, we have got reconfirmations about this while we did the systematic review and meta synthesis of qualitative research on TB. This is a recent review. We are just in process of submission. But what we understand from this synthesis is that the cultural aspects play a key role in TB treatment adherence, and also various contributions like the stigma, TB associated stigma is very significant part of treatment adherence. So how far are we? What are we doing? What is being done? Is it enough? Yes, we have done a lot. The civil society and TB survivor advocates and many other stakeholders have been advocating for addressing the various aspects of social aspects like stigma and discrimination. And recently, the national program has taken up a very strong stand. They have started TB champions training, in which the TB survivors are being trained as champions, and they are being supporting peers in understanding TB and in completing their treatment, counseling, advocacy for various aspects. We also have come up with a strategy to end stigma and discrimination. This document was prepared with the partners and the program, and this was launched last year in the TB Day. We have community engagement guidance that has been developed, and right now across the country various people are being trained on this community guidance, how to engage communities, how to address these aspects of stigma and other social aspects. We also have self-learning toolkits that have been launched by the National TB Program to become TB champions, how the TB survivors can become champions and advocate for this. This is a great move, and we are progressing. Yes, we also have another great initiative that has come up, which is the National Technical Support Unit, which was established specifically for advocacy, communication, and social mobilization. Now, this was started with a objective to create a Jan Andolan. What is a Jan Andolan? Jan Andolan is a people's movement. It is not the National TB Program. It is not key stakeholders or the civil society. It's only few organizations or few individuals. It is of everyone. It's a people's movement. Unless everyone in India knows about TB, the approach that should come from bottom up and not from top to bottom. So unless everyone talks about TB, we cannot destigmatize TB. So to have a TB Mukt Bharat, which is now the campaign that is running, it is called the TB Mukt Bharat Abhiyan. And unless we have this campaign coming from the bottom up, it's very hard for us to move forward on this. So yes, as I said earlier, we are making progress, and we have to continue to evaluate ourselves. And to have a TB Mukt Bharat, we need to have a TB Stigma Mukt Bharat. That is something which we need to work towards it, and I'm sure we will do it. Thank you.
Hi, everyone. My name is Ravandi Nathavitharana. I am an infectious disease doctor and assistant professor of medicine at Harvard Medical School and the chair of TB Proof. I'm really delighted to be here today to talk about intervention design to end TB stigma. So as part of our panel, we've been hearing a little bit about what stigma is, and I wanted just to reiterate about stigma being differences, starting with differences being linked to negative stereotypes, which lead to a separation of us versus them, and this leading to a loss of status for those people who are ascribed to be different. We know that stigma is a barrier to high quality TB care delivery, but what we don't know is how best to target stigma reduction interventions and how best to design and implement them. I wanted to showcase this piece of art by Paulina Sinyatkina, a Russian TB survivor who I think work sort of encapsulates these components of stigma that are experienced in terms of both enacted, internal, as well as anticipated stigma. So just to sort of go a step back and sort of discuss a conceptual framework for stigma, we have drivers of stigma, which may include aspects such as blame, facilitators of stigma, which may relate to how TB clinics or hospitals are set up with TB patients being segregated, for example, or how messaging sort of focuses on negative aspects of sort of risk and people feeling like they're risky behavior, whether it's related to substance use or dual conditions such as HIV that has led them to get TB. And this then leads to manifestations of stigma. And the three that I'm going to focus on are anticipated stigma, internal stigma, and enacted stigma. And I'm going to give you a couple of examples of that. So anticipated stigma is where there's a worry about what may happen to them. So for example, a fear of gossip or a fear of other repercussions across a variety of spheres in their lives. Internal stigma, which may be driven by blame, for example, leads to a negative self-perception and bad feelings about themselves. Enacted stigma may be in the community, for example, loss of respect or loss of standing, or in the work arena with the loss of job, for example. And these types of stigma can impact TB care across the cascade. So they can impact a variety of cascade outcomes. So care seeking, treatment initiation, adherence, retention, for example, not comprehensive. We conducted a scoping review where we looked at, we initially screened 1,400 abstracts and it basically extracted data from 9 studies. What you can see from the range of ages, so these studies sort of go back from 2003, and then the most recent one in this review was from 2019. The studies came from a variety of countries, from South American countries such as Peru and El Salvador and Nicaragua in Central America, as well as African countries such as South Africa, Nigeria, Ethiopia, Asian countries such as Taiwan. And we broke these down into different types of interventions. For example, a lot of them focused on psychosocial support groups, other support groups. So either led by, for example, in Peru, led by a psychiatrist and nurse, versus TB clubs led by TB survivors. Other interventions included educational workshops or educational videos. Another intervention included participatory theatre with health workers. And these targeted different domains of stigma at largely the individual, sometimes the community level, and sometimes the interpersonal level where households or other contexts of someone with TB were involved. But you'll notice that none of them targeted the policy level, which is a gap in intervention design. And you can see that with only 9 studies, there really is limited data on this topic. So few studies actually differentiated the interventions by stigma domain, and the definitions of stigma varied. There's wide heterogeneity, a lot of variability in the approaches used to measure stigma within the interventions and how these were reported, and implementation outcomes such as how was this intervention delivered, who delivered it, what was the fidelity, what was the access, what was the penetration, for example, were sparsely reported. So this really led us to conclude there's really a need for targeted and context-specific interventions to address the different domains of stigma at different stages of the cascade, including at the policy level. So we did a mixed method study in South Africa, and this was led by TB survivors working as peer research assistants, and they were conducting community-based stigma assessments using an adapted Stop TB partnership questionnaire, as well as in-depth interviews in 2 regions, an urban region Khayelitsha and a rural region, Hammanskraal in South Africa. And the participants were people who had had more than one episode of TB or caregivers of someone, including children who had had TB. And the project is called Use My Voice to End TB. So how we broke this down is, so I'm going to show you some of the preliminary results for the surveys rather than the qualitative interviews. And we broke this down across the stages of the cascade. So care seeking, diagnosis, treatment initiation, and treatment completion. And what you can see is there were high levels of internal stigma and anticipated stigma in people who had TB, and much higher levels of internal stigma for the caregivers at this sort of stage between care seeking and diagnosis. Again, between diagnosis and treatment initiation, fairly high levels, over 10% of internal stigma, almost 10% for anticipated stigma. Again, higher levels for internal stigma expressed by the caregivers. And then as you go to treatment completion, these rates go down, but still consequential in terms of internal anticipated stigma, not much enacted stigma, the proportions were much lower, but still very high rates of internal stigma expressed by caregivers. And so, and then two of the questions that came up were asked in the survey that we thought we could sort of analyze in terms of the gender response to stigma. One of the statements was, I probably got TB because I smoke, drink, or do other careless things. And you can see that a higher proportion of males, 47%, agreed compared to 16% of females. Another statement in the survey was, I've lost respect in the community because I had TB, which is around their internal stigma and also potentially around anticipation of stigma or enacted stigma. And in this situation, for this question, 13% of males agree compared to 58% of females. So you can see that there are differences in how stigma manifests across different genders. An example from the Indian context was a study done in Pondicherry where they did in-depth interviews and focus groups with people living with TB, household members, and healthcare workers, which showed very high variability in TB knowledge and high levels of anticipated stigma. One of the quotes was, people listen more to what actors say, which is why I chose this figure. And so participants from this study supported interventions such as celebrity advocacy and school-based programming. So what you can see is that we can use these types of contextual data to try to design interventions that are acceptable, feasible, and then hopefully effective in those communities and in those regional or district settings. So we attempted to, as part of our work, try to put this into a framework where we thought about what were the drivers of stigma, such as blame, misunderstanding, prejudice, lack of awareness, and fear of infection, and then targeting the manifestations, so internal, anticipated, or enacted stigma, and to think about breaking these interventions down at the different levels, so individual levels such as skills building and coping workshops, coping mechanisms, interpersonal and individual could be incorporated with support groups. Community level could be advocacy campaigns or engaging with people in households affected by TB, skills building workshops or informational campaigns. And then at the policy level, this is important in terms of laws, policy language, and programmatic documents. So this was just a sort of a snapshot of the way one might approach designing and implementing stigma interventions, and look forward to discussing more. Really wanted to thank our amazing team in South Africa, partners of TB Proof, funded by the Stop TB Partnership, and our research collaborators are at Stellenbosch University. This is our community health workers in Hammanskraal. Thank you very much. Look forward to questions.
Hello, I'm Ashna Ashish, an MDR TB survivor, a lawyer, and a public health professional. And I'm here on this panel on addressing stigma to ensure equitable and accessible TB care in India, to talk to you about what are the legal resolutions to stigma in TB. So just a quick background before we get into this. TB remains a highly stigmatized disease in India as elsewhere, and TB-affected individuals face stigma and discrimination in workplaces, communities, families, and even healthcare settings. When we try to understand the impact of the stigma, we have to look at it in terms of two things. One is the human cost, and the second is the public health cost. The human cost is that stigma can cause TB-affected individuals to be isolated and alienated from community and loved ones. And this kind of isolation and loneliness often leads to feelings of guilt, depression, and anxiety in the affected individual. It also makes it difficult for people to then admit to having TB or seek care for it, or to declare that they are TB affected. And often what happens is that people may not even seek treatment for the fear of being stigmatized, because the fear creates that kind of environment for them. What happens then is that left untreated, TB can spread in the community, and this is where it then threatens our public health goal of eliminating TB from India by 2025. There is no eliminating TB unless we address TB-related stigma, and yet stigma persists. Why? So we have to understand that what's happening now in terms of addressing stigma suffers from a few limitations. And broadly, in terms of an overview, this involves a failure to recognize that stigma is also at an institutional level, in workplaces, in healthcare settings, in educational institutions. There's also a failure to recognize TB-related stigma as a rights violation and a failure to provide remedies for discrimination against TB-affected persons. Now, why legal resolutions to stigma? What would that accomplish, right? So public health legislations and accompanying policy can bring about a shift in public perception. There's a certain value signaling that something like the law does, which says that certain things are okay and certain things are not, or are inhumane or unethical or illegal. It also helps to change discriminatory practice in private and public institutions. It provides remedies to address effects of stigma, and it protects the rights of the vulnerable. And we've seen an example of this in HIV, where the anti-discrimination legislation for people living with HIV has sort of succeeded to some measure, at least in normatively recognizing all of this, and is gradually being implemented. TB can learn a lot from the lessons of HIV, whether it's the persons living with HIV who have organized and advocated for changes, whether it's lawyers and civil society that came together to work with PLHIVs to bring about this anti-discrimination legislation. So what should the aim of these legal resolutions in TB be? There are two things. One is a preventive aspect, which is to prevent stigma and discrimination. So the legislation needs to outlaw stigma and discrimination and certify it as illegal. The other is a curative aspect, which is to address the effects of stigma and discrimination. So if as a TB affected individual, I'm discriminated against because of my illness, I should have some recourse. I should have some grievance redressal mechanism where this can be addressed, right? What are the possible legal resolutions? Now, on legislation specifically for TB affected persons, along the lines of HIV anti-discrimination legislation, along with accompanying stigma mitigation policies with workplaces and resident welfare associations and healthcare settings sort of mirroring this legislation to ensure its effective implementation. Now let's have a look at what should the legislation do. To begin with, it should be horizontally applicable to public and private institutions as well as individuals. What this means is that if, as a TB affected individual, I am discriminated against because of my illness by the state or a private organization or an individual, I should have a recourse for this rights violation. The second thing that it needs to do is make stigma and discrimination a punishable offense. And it also needs to ensure that because somebody has TB, solely for that reason, they are not denied access to safe housing, an opportunity at employment or education, or access to healthcare, or entry into any kind of establishment, or denied services or goods. A couple of other things that this legislation needs to focus on is providing for a grievance redressal mechanism and detailing its workings, and providing for the details of administration of this legislation. Now, what do the accompanying policies in this have to look at? So let's take the example of workplace and healthcare. Workplace policies need to ensure an inclusive, supportive environment for TB-affected employees, a complaints mechanism to remedy discrimination or stigma, and in the healthcare setting, because here you go with the expectation of care. This is the last place where you expect stigma or discrimination. Even then, it does sadly exist. So we need policies here as well. And what they need to do is for that stigma-free, dignified, high-quality care. Also provide a complaints mechanism to address stigma in such settings, and penalty for health providers that stigmatize or discriminate against TB-affected individuals. Now, all of this would be incomplete unless you have a public awareness about these legal resolutions, because it's just a law on paper until people, not just the people enforcing it, but also the people it applies to, are aware about it. And that is key to successful implementation, creating that awareness about various things. And this can be done through national and regional governments to actively create public awareness on the issues using multilingual campaigns that focus on the rights of TB affected individuals, the legal penalties for stigma and discrimination, as well as the legal remedies against stigma and discrimination. Stigma makes it difficult for people to live and easier for TB to thrive. To address it, we need every tool we have in our box. And one of the most critical tools, though not the only tool, but still an important one, is legal resolution. We need the strong arm of the law to weed out the pernicious stigma attached to TB. Because without a stigma-free India, there is no TB-free India. Thank you.
Thank you for joining us today for this insightful and critical session. Through our panel, we just saw how TB-related stigma is a threat to the health of the individual and the society as whole. These presentations offer some crucial learnings that TB stigma puts a dent in India's public health goal of TB elimination by impacting willingness to seek care and complete treatment, that our health system and policy makers suffer from a lack of understanding about stigma. It is crucial to understand the multiple aspects of stigma and use multiple approaches from community-based advocacy to the law to mitigate TB-related stigma. TB care has to be stigma-free to be truly accessible and equitable. There is no ending TB without ending TB-related stigma. Thank you for joining us today.